June Dorsey is a 45-year-old female, 167 centimetres tall and weighing 56 kilos. She presented to her local GP with a history of nausea, anorexia and a general feeling of tiredness. She recently vomited about a cupful of fresh blood, which has made her quite worried. Even though she has long-term weight loss, she has recently experienced some weight gain, even though she is not eating well. The weight gain has been almost exclusively on her abdomen. Over the last few days, she feels she has a yellowish tinge when she looks at her eyes in the mirror. During the history taking, she informed her doctor that she drinks alcohol every day and estimates her intake at anything from 3 to 6 bottles of wine per day. This has been her normal intake for the last 10 years. She suffers from hemorrhoids, which bleed profusely on occasion.
The liver is the largest gland of the body, located in the upper right side of the abdomen, and it is part of the digestive system. It performs several life-sustaining functions. It processes nutrients, produces proteins, stores sugar or glycogen, and it controls the body's hormone levels, blood sugar levels, cholesterol levels, and fluid retention. The liver filters unwanted substances and helps the body fight infection. Cirrhosis is chronic progressive inflammatory disease. Damage to the liver from alcoholism or illness causes inflammation, which produces an increase in growth factor of extracellular matrix, which produces scar tissue, which develops in healthy liver tissue. Scar tissue prevents blood flowing through the liver, preventing it from functioning properly. The hepatic system consists of the liver and all functionally related structures. The liver is unique because it has a dual blood supply, the hepatic artery and the portal vein. The terminal branches join to form a common capillary bed. Thus, a mixture of venous and arterial blood bathe the liver cells, also known as hepatocytes. The functional units of the liver are cylindrical structures called lobules, and there are about 100,000 in the liver. Each lobule is organized around a central vein and empties into a hepatic vein, and from there into the vena cava, which brings blood from the lower half of the body to the heart. When the blood travels through the liver, cells called Kupffer cells remove waste products, old and defective blood cells, and other foreign material. The breakdown of defective red blood cells creates a pigment called bilirubin. The hepatocytes remove bilirubin from the blood and modify it so it can be secreted into the adjacent small bile ducts called bile caniculi. Bile caniculi pass the bilirubin across the common bile duct into the duodenum. At the duodenum, muscle tissue called the sphincter of Oddi regulates the flow of bile into the duodenum. When the sphincter is closed, the bile moves back into the common duct and down to the gallbladder where it is stored. The liver removes toxic digestive products such as ammonia from the blood by converting it to urea for excretion by the kidneys. Cirrhosis is the end stage of chronic liver disease when much of the functional tissue is replaced by fibrous tissue. Primal biliary cirrhosis involves inflammation and scarring of the intrahepatic bile ducts, portal inflammation, and the onset of progressive scarring, which leads to liver failure. The liver becomes enlarged and takes on a green hue because of the accumulated bile. Scarring continues and the liver begins to shrink as the fibrous tissue replaces normally functioning tissue. This leads to portal hypertension and liver failure. Portal hypertension is excessively high pressure in portal veins. It develops when resistance to blood flow into and through the liver is increased because of the scarring. Blood begins to back up, leading to venous dilation in the esophagus and the legs and the rectum, which leads to distended vessels called varices, which can rupture under pressure or trauma, resulting in hemoemesis or melena in the feces. Blood that normally enters the liver via the portal vein begins to bypass the liver. Portal hypertension results in ascites, the accumulation of free fluid in the peritoneal cavity from the blood that diverts from the liver to the abdominal peritoneal vessels. Due to increased capillary pressure, fluid leaks into the interstitial spaces and into the cavity. The body releases ADH and aldosterone, which increases fluid retention. Sodium and water retention builds and abdomen becomes distended and bloated, peripheral edema starts to occur, and dehydration signs such as sunken eyes. Jaundice is yellow skin and eyes from the inability of hepatocytes to clear bilirubin levels as normal, and it can result in frothy urine and pale stools.
There are 5 main types of assessing and diagnosing if someone has cirrhosis. This includes visual examination, imaging, taking bloods, endoscopy, and a liver biopsy. These are listed from least invasive to most invasive methods. A visual assessment includes checking for signs of bruising, tenderness, hepatomegaly and splenomegaly, and distension around the abdomen. Also knowing the odor and color of the eyes and skin can be key indicators of a liver disease. Imaging uses ultrasounds, MRI, or CT scan pictures to show evidence of advanced liver failure. Ultrasounds are often used as the first choice of imaging as they are simple, cost-effective, and less invasive. Through the use of the pictures, abnormal shapes, nodules, and hypertrophy will be seen. However, if these qualities are seen in the ultrasound, it is recommended that an MRI or CT scan is also used, as this will provide a more detailed and reliable image of the liver. Bloods are one of the most conclusive methods of diagnosing and offer a lot of information about what is happening with the liver. This procedure takes place by simply withdrawing blood from the patient's veins and examining the different qualities of it. Checking the liver enzymes such as AST and ALT levels indicate if there is any liver damage occurring. Increased presence of alpha-1 antitrypsin also indicate potential infection in the body. In the case of cirrhosis, these levels are elevated as the body attempts to compensate for the decreased function rate of the liver. Reasoning for this is when the liver encounters a degree of damage, these enzymes leak out and therefore become more present and detectable in the blood. This is due to the body's inflammatory response. The vessels become more porous and therefore allow these enzymes to transfer into the blood. Similarly, looking at the presence of gamma-glutamyl transferase enzymes showed the evidence of potential liver damage. Gamma-glutamyl transferase enzymes present an activation of the enzymes which are used to fight and provide protection for the body. Commonly, these enzymes are present as a result of the injured or poor functioning liver. Testing the levels of albumin gives a clear indication of how well the liver is operating. Assessment and identification of cirrhosis. It is essential for the healthcare team to be extremely confident in their diagnosis. It is important that the diagnosis is correct and has substantial evidence to support it. By undergoing an endoscopy procedure, the team can be certain of the condition in which the patient has presented with. An endoscopy is using a tool to view desired portions of the body internally, which in this case is that of the liver. The team are able to view the liver by entering through the mouth and following the appropriate track to the liver. Visually, cirrhosis causes severe scar tissue to develop around the liver. Therefore, the organ often has uneven, raised surfaces covered with small nodules. This visual confirmation can help easily determine the patient's illness and can therefore help the healthcare team to move on to treating and managing the condition. Biopsy is considered as one of the last resorts in diagnosing cirrhosis. This method is often avoided when possible as it is the most invasive and extremely expensive. This procedure requires the doctor to administer local anesthesia to the abdomen site, then make a small incision with a needle to remove a sample of the liver. Although this investigation is expensive and invasive to the patient, this process only takes about 5 minutes to complete. In the case of chronic liver disease, this would not be considered as a necessary step as this investigation would add no further benefit to the patient.
The nursing management of a cirrhotic patient is often related to whether it is an alcoholic, post-necrotic, or biliary cirrhosis, since these have their unique features. This management includes ascites by restricting patient from salt and diuretics, monitoring the dietary intake of the cirrhotic patient to avoid future obesity, screening for alcohol, and patient education on risk factors such as sexual intercourse, alcohol consumption, and physical activity. Monitoring for complications. Cirrhosis could lead to complications such as ascites or portal hypertension, etc. Therefore, observe and document for bleeding gums as hemorrhagic episodes could easily occur. Also, monitor for epistaxis, petechia, and degree of sclera. Stay with patient if such episodes transpire and provide comfort and reassurance. Regular check of patient's mental status is important. This is because such patients are easily malnourished, thereby feeling lethargic and confused, and such could lead to complications of hepatic encephalopathy for possible changes that may occur. Additionally, cirrhotic patients should have a medical checkup at least twice a year after being discharged, monitoring abdominal ultrasound to check if there is any symptoms of advanced liver disease, and notice for development of portal hypertension with symptoms such as jaundice. Medication therapy such as antibiotics, potassium diuretic, furosemide diuretic, lactulose, propanol hydrochloride could be used. Dietary sodium restriction. Water retention and fluid overload is mostly a significance of cirrhosis, especially ascites. Therefore, it is important that the risk of edema is reduced, controlled, which implies that a negative sodium level is maintained, thereby increasing the amount of fluid output. The patient has to be educated on its importance. For instance, letting them know that at least 2 grams of sodium should be consumed per day. Likewise, a cautious monitoring of serum electrolytes is essential and should be corrected if atypical. Therefore, a cardiovascular and respiratory assessment should be conducted regularly, and abnormal symptoms such as irregular heartbeat, pyrexia, numbness, or twitching should be documented. Also, inspect and examine stools and vomitus for quantity, color, and constancy. diuretic therapy aims to minimize sodium reabsorption and increase renal sodium excretion. A combination of two diuretics such as furosemide and spironolactone can help, for instance, using both doses in the morning, and also a careful monitoring is required to avoid excess fluid output and electrolyte imbalance, which could lead to renal failure. Skincare. Regular repositioning of patients is important to avoid complications of pressure sores or wounds. This is because patients with diuretics are expected to excrete a lot of fluid, either by sweating or polyuria. These patients should use the right products and avoid skin irritation and skin lotions to control dry skin or skin opening. Educate patients against consuming any non-steroidal or anti-inflammatory drugs. Instruct patients on the importance of rest and good nutrition. Advise patients to alternate regular exercise and rest to optimize good flow of oxygen. Encourage and thwart lethargy. Encourage the patient to have enough rest with legs elevated to prevent edema and ascites. Advise patients about the complications of alcohol consumption and its effects on the liver. Therefore, it should be minimized or stopped. Also, a liver transplantation might be needed if cirrhosis deteriorates.
When a patient takes an angiotensin II receptor blocker, it binds to angiotensin II receptors in the vessels. This prevents angiotensin II from binding. As a result, vessels widen and blood pressure falls. Loop diuretics, labelled here LD, work by blocking the sodium-potassium dichloride symport. Thus, loop diuretics work by preventing the reabsorption of sodium, potassium and chloride. The result is the passing of excess amounts of fluid. This reduces portal hypertension and ascites. Potassium-sparing diuretics, for example spironolactone, labelled SPL, work by blocking the aldosterone receptor, inhibiting its effects, decreasing the reabsorption of sodium, thus reducing oncotic pressure. The action of beta blockers is based on blocking the beta-adrenergic receptors, which bind adrenaline and noradrenaline. The effect is to decrease the heart rate and thus cardiac output. This reduces blood pressure.
Liver cirrhosis is a deadly but preventable disease. It's primarily developed from viral hepatitis, fatty liver disease, and alcoholic liver disease. In 2012, it led to the premature deaths of 1,204 Australians. Among these, more than 2/3 were young males. In 2015, the Australian Bureau of Statistics classified liver cirrhosis as the 20th highest risk factor for premature mortality, disability, and loss. It accounts for 50% of alcohol-related deaths worldwide. According to World Health Organization, approximately 16% of drinkers aged 15 or older engage in heavy episodic drinking, and in 2012, 3.3 million net deaths were attributed to alcohol consumption. Consequently, public policies such as the Australian Guidelines to Reduce Health Risks from Drinking Alcohol and the National Aboriginal and Torres Strait Islander Health Plan was introduced to influence alcoholic drink culture and prevent binge drinking. Fatty liver disease. Despite public health campaigning, Aboriginal and Torres Strait Islanders have a substantially higher risk of developing liver disease. In 2012, Aboriginal and Torres Strait Islanders' age standardised death rate due to liver cirrhosis was 4 times higher than the non-Indigenous people. Between 1980 and 2012, male mortality rates from liver disease has halved. This is thought to be due to effective disease management and prevention. However, this rate has remained approximately the same for the females. The cost of treating liver disease in 2012 was approximately $432 million. This encompasses primary treatment, prevention and management of comorbidities such as hepatic encephalopathy or gastric varices. The combination of public health promotion and advancements in disease management has contributed to the gradual decrease in mortality rates. Further efforts from the Australian Government to improve primary prevention and public health access will assist in eliminating the burden of disease altogether.